Now we will start HCC5, Current Status and Future Perspective of Transplantation. The moderators are Professor Hideki Odan and Professor Yoshihide Ueda. Moderators, please start.
Good morning, everyone. Welcome to the HCC 5 session entitled Current Status and Future Perspective of the Transplantation. I'm Hideki Oda from Hiroshima, Japan, a co-moderator of Professor Yoshihide Ueda from Kobe University. And we invited a renowned Professor Kiyoshi Hasegawa from Tokyo, Japan. Each talk are given the 20 minutes followed by discussion. Each talk focus on the specific issues we discuss by and by. And then it's a great honor for me to introduce first speaker, Susumu Eguchi from Nagasaki University. He's going to talk about the current status of machine perfusion for liver transplantation. Professor Eguchi, please commence your talk.
Thank you very much, Professor Odan and Professor Ueda for kind introduction. And it is really pleasure and honor to have such opportunity. I'm really thankful to Professor Shina for giving me such a big occasion. Well, this topic is not really related to HCC, hepatocellular carcinoma, but it's a really current hot topic in liver transplant field. So I'll talk about current status of machine perfusion for liver transplantation, especially we can apply, whether we can apply in Japan or not. COI, my group is, we have a kind of a project group with Screen Holdings. This is current situation with liver transplant number in Japan. We have up tempo for the cadaveric DVD donation recently. Last year we have more than 120, approaching to 150 per year. But still, we are depending on the living donor liver transplantation because of the lack of the donation after death. And this is a global view of our numbers. Left side is the deceased donor. We have still low per PMP, population per million population. We have we can count from the tail. And for the living donor, we are still depending on the living donor a lot for the liver transplantation. So we need to maximize the utilization of a limited number of organ donation. It's very highly important. So what we can do is we should or we can adopt the extended criteria donors with a favorable post-operative outcomes. We can select it. We can choose it based on the evidence. And ECD, we can call extended criteria donor. In the Europe and the US, they started to open the field of DCD, not DBD, for the donor source. And their percentage of DCD, death after cardiac death, donation after cardiac death, sorry about it. In Spain, almost 30% of the donation is DCD, not DBD. So, but the problem with DCD is, possibility of primary non-function or biliary complication after liver transplantation. For such occasion, machine perfusion, MP, we call it MP, it can solve the problems in that setting. So, I'd like to explain about the nomenclature of a machine perfusion. So if we say normothermic perfusion, it means 35 to 37 degrees Celsius. And if we call hyperthermic, it's usually less than 12 centigrade. And I don't tell about SNMP, which is a sub-normothermic MP, and also mid-thermic MP. This is a kind of nomenclature. Please put it in your brain. So normothermic versus hypothermic. There is a two technique of machine perfusion in liver transplantation. If you, the advantage of NMP, normothermic machine perfusion, the donor organ is metabolically active because of the temperature, but it needs oxygenation. So high cost and oxygen carrier is needed, but you can assess the function. So bile is coming when you are perfusing the organ. On the other hand, if you perfuse hypothermic and oxygenation, we call it HOPE. We can resuscitate the mitochondrial function, so ATP can increase after HOPE. And it's relatively simple and safe and low cost. However, we cannot assess function. We don't have a bile during the HOPE. But it's relatively, even if the line is clogged, it's just going to the static, preservation. So not risky at all. So this is a result of NMP, normothermic. This is published in Nature Communication a couple years ago, and they selected the extended criteria donor or even possibly discarded donor, and put it on the NMP. Then they have a criteria to transplant. They transplanted it, and this is a result. So result is the same. So if we perfuse NMP in the DCD donor, if they select well, the liver can be salvaged. Very nice. Median NMP time is almost 10 hours. So this is their criteria. So after NMP, if the lactate level went down to 2.5 and other parameters became good, they transplanted it. Then they have almost as good as the outcome with just normal liver transplantation. So this is also NMP study. There are a lot of publications. They follow the verification. And Quintini, Cleveland, and the other facility, they transplanted after NMP with the liver, which is possibly discarded. And their salvage percent is almost 70%, their transplant rate is 70% after NMP, which could have been discarded. And this is a result of HOPE, hypo. And basically, European group is really keen on it. And this is a RCT randomized study for the DCD liver transplantation, 2 hours dual HOPE. Dual HOPE means artery and portal vein. D-HOPE, they did D-HOPE and the reduction of biliary stricture, 68% reduction, and 57% of reduction of post-perfusion syndrome. So DCD, even with HOPE, it's still we have a benefit, and very simple. And this is HOPE and DBD, not DCD. Previous slide is DCD. This is DBD. So they have RCT for DBD with HOPE. And the result was complication rate, etc., became better with HOPE for the DB, even for DBD. So we can salvage the extended criteria donor, aged donor, etc., even with HOPE. So this is the current protocol of selection of way to go in the Netherlands. The regular DBD, there's a static preservation and transplant. Regular DCD, they did a D-HOPE, and the ECD, DBD, this third from the left, they do the D-HOPE, and very high risk DBD or DCD, they do the HOPE and endoischemic normal NMP to evaluate really this liver is functioning, and if it's not functioning, they discard it. So this is their algorithm. So how can we apply it in Japan? we have no DCD at present for the liver transplant in Japan, and maybe we have a longer ischemia time as compared to US, because in Nagasaki, we have always 10 hours, over 10 hours called ischemic time. So in the States, 4 hour, 5 hour, because they have an area. But we have a whole nation transportation system applied. So we have a relatively longer ischemic time. And the elderly donor becomes more, I guess, because we are in the aging society. So we still have DBD with the risk factors to be considered for machine perfusion in Japan. So I think this area in Japan, we can apply the machine perfusion even for the DBD with extended criteria, complication. So this is, I'd like to show our effort to make some machine. There are many established machine perfusion from Europe and the United States. The famous one is Organox and the Transmedics. So if you'd like to use these machines, we have to import it, which could be very expensive. And NMP, oxygen carrier, is very expensive, and whole blood. So we'd like to do it HOPE. I was in the Groningen in the Netherlands, and they have been doing such a research. So we have a connection with them. So then we started to collaborate with the Screen Holding, which is kind of semiconductor washer company. And this is our system. We have HOPE. We are thinking about HOPE, but we could be applied for the NMP. We have a pumpless. So we are just use the height difference, pressure difference, and separated chamber. I will show you the video. So this is our prototype machine. And this pump is just raise the fluid from up high, from down, then just perfuse it with height difference, positional difference. So if the pressure comes up, they can just automatically stop. So we don't have a worry about the blow. This is a normal somothermic hypo. And the appearance of the liver after HOPE becomes like this. So maybe we can still use for the living donor. In the living donor, partial liver, there are a lot of dumps in it. So we can flush it, and it could be better, actually. And so this is donors. This is our, the presumption, donor surgery, and back table. This is a porcine model, liver transplant. We do the experiment of liver transplant in pigs. Donor surgery, like harvesting, like DBD, and perfuse with, first perfuse with UW, and change it to HTK for the HOPE perfusion, and do the recipient surgery. So this is a preliminary observation in the NMP and the HOPE for our result. I think we can, you will see it in the publication. And the advantage of machine perfusion is, as I said, increase the number of transplantable donor liver in aging society, and split, etc. And also we can improve the outcome after transplantation. So reduction of, ischemia perfusion injury, and to reduce the PNF and cholangiopathy after liver transplantation. And in addition, we can have facilitated logistics. It means we can adjust the preservation time, and we can also avoid the nighttime surgery for sustainability in organ transplantation. So liver transplantation is always urgent surgery. We are proud to do it in the midnight. However, for the sustainability for the young surgeon, it can be done next morning, like kidney transplantation. So the example of a schedule when organ arrival at night, when the daytime procurement and the When organ comes to our hospital in the midnight or evening, we can put the liver in the machine perfusion, long-term hope probably, and prepare it and concentrate it, and then liver implantation from the morning, like kidney. Then we need a long-time hope, because in the Europe they have only 2 hours, 3 hours hope for DCD. So this paper shows 10-hour long hope, long hyperthermic oxygenation of perfusion. So the long hope is becoming valid. Then we are able to do kind of logistic facilitation for the younger generation of transplant surgeons. Finally, I'd like to show some result of HCC recurrence after liver transplant via machine perfusion, whether they increase or reduce. I find it. And the neurosurgery a couple of years ago, they showed efficacy of HOPE, hypooxygenated machine perfusion, HCC recurrence. According to the literature, 5-year recurrence rate with HOPE as compared to static cold preservation, which we do right now, is much lower with HOPE because of improvement of, I think, vessel wall in the liver, 4 times higher tumor recurrence rate with DBD and DCD, but they have some. This is a DCD hope. This is DBD SCH. And experimental-wise, they have there is one study of impact of machine perfusion HCC recurrence after DCD transplantation. So this is a rat study. So they just implant the HCC in the animal after they have a HOPE and the normal NMP and the cold preservation. And this study showed there's no significant difference of the recurrence rate or attachment rate in the graft liver, among the group. So they are still controversial, but at least machine perfusion would not, I think, increase the tumor recurrence after liver transplantation. So in conclusion, ladies and gentlemen, we have developed machine perfusion device for both HOPE and future implementation of the NMP. We are planning to clinical research from next year to validate our system is safe or not. Thank you very much for your kind attention.
Well, excellent talk. Thank you very much, Professor Eguchi, for introducing us innovative technology of machine perfusion, which can improve graft quality and probably expand donor selection criteria. Is there any comment and a question from floor? Yes, please.
Thank you. Very interesting presentation. I'm Elena Palma from the Roger Williams Institute of Pathology in London. I have a question regarding regenerative medicine. If there are any studies that show that adding to the machine perfusion other intervention are beneficial for the organ.
Thank you very much. It's a very interesting topic. And there are many researches going on with the combination of machine perfusion and stem cells, like mesenchymal stem cell from fat or something. And in the publication, they show the improvement of liver with a combination of the MSC in the system. So I think I think you have an answer, I guess, or not.
No, it was just that I had another question if they added directly to the machine perfusion. So
yeah.
that
According to literature, addition of the MSC, mesenchymal stem cells, in the system, they increase the function of the liver after transplantation or bioproduction, something. Yes.
And can I ask another question?
Sure.
You show at the beginning the difference between hypothermic and normothermic, and I was wondering about the mitochondrial function.
Yes.
What is the difference between the two?
Well, actually, thank you very much. With HOPE, we cannot assess the function because of the less oxygenation. So the main target of the HOPE is to increase the mitochondrial function. That is it's really their nationale for the HOPE. And right now, they have a surrogating marker in the serum to check flavionic acid or something to check the mitochondrial function in the system, perfusate, and also blood. So I think HOPE is targeting the increase of mitochondrial function of the liver, not really assessing. But reconditioning is possible with the increase of the mitochondrial function. So that is a HOPE.
Do you know if anyone have ever tried to do mitochondrial transplantation, so to add mitochondria in the context of the liver? I know that for renal transplantation has been.
No, I have no knowledge. Mitochondrial transplantation. That is fancy.
Thank you.
Thank you.
Probably I took misunderstand. You said you are saying you don't need a pump, but on your picture, your machine it was equipped with a pump. The pump just for the oxygenation?
No, thank you very much. Pump is just raise the perfusate from down to up.
I see.
In the European system, they have a positive pressure pump to perfuse the liver itself. But our system just raise the perfusate from a basin to the up high pump. Then we just perfuse with a height difference, positional gravity. That is a difference, actually. Yeah.
So how the perfusate can be the oxygenized?
Yeah. Oxygenation can be done everywhere.
Oh, I see.
Yeah, everywhere.
Okay.
Like ECMO.
Professor Hasegawa.
Thank you, Professor Iguchi, for your nice presentation. I'm Kiyoshi Hasegawa from the University of Tokyo. I am interested in the impact of HOPE on the recurrence after liver transplantation or HCC. What is the potential or theoretical advantage of HOPE in the liver transplantation or HCC?
Yeah, thank you very much. I think according to the literature, I think even short-term HOPE can improve the endothelial function or integrity, make it better before transplantation. So I think attachment of the HCC cells to the graft liver could be reduced because of the less injury of the endothelial cell of the liver. That is their rationale, but it's not really proven yet in the animal study.
Thank you. Very interesting. Thank you very much.
Maybe related question. Is there any evidence showing us the patient receiving marginal graft have a high risk for the recurrence?
I guess so.
Probably some paper tell us that.
Yeah, I believe so, but sorry, but I didn't dig up the literature. But I believe that it's attachment, adhesion of the HCC to the damaged endothelial cell could increase. But I don't have evidence, so I have to check. Thank you.
So it's a true, maybe living donor liver transplantation should be the preferred to the deceased donor liver transplantation in terms of the risk of recurrence of HCC?
Yeah, could be. I think so. Yeah.
Any other question from Flora? Whereas advancements of this kind of technology probably improve the outcome of the liver transplantation.
Yes.
Thank you very much for
also logistics of the young surgeons.
And they expand the donor pool.
Yes.
Well, thank you very much.
Thank you very much.
Okay.
Second speaker is Dr. Masahiro Ohira. The title of this presentation is Liver Resident Natural Killer Cells as Adjuvant Treatment for Hepatocellular Carcinoma Post-Liver Transplantation. Dr. Ohira, please.
Thank you very much. I'm Masahiro Ohira from Hiroshima University. First of all, I'd like to thank President, Professor Shina, and the Chairman, Professor Oda and Professor Ueda. Today, I'm going to talk about the liver-resident NK cells as adjuvant treatment for HCC, post-liver transplantation. So we have nothing to disclose. So let me explain the concept of liver NK cell therapy. So during the liver transplantation, all cancer cells are removed from the donor, removed from the body with the liver. Theoretically, liver transplantation can HCC completely. However, micro cancer cells existing before transplantation or small cancer cells squeezed out from the liver during the surgery can proliferate due to the immunosuppressive drugs after liver transplantation. That's causing the HCC recurrence after liver transplantation. NK cells have been reported to play an important role against the circulating tumor cells or micro metastasis. So we have developed an adjuvant immunotherapy using donor liver NK cells for preventing HCC after liver transplantation. So I'm going to talk a basic study of liver-resident NK cells, and then we're going to introduce donor liver NK cell therapy in clinical setting. So why do we use NK cells? Because NK cells attack the target cells by these three pathways: granule exocytosis, this receptor pathway, and interferon gamma pathways. So NK cells recognize the self and non-self, and also can target cells very quickly. So the immune system consists the adaptive components, including T cells and B cells, and innate components, including NK cells. Immunosuppressive drugs after liver transplantation mainly suppress the adaptive components. So innate components like NK cells relatively maintained after liver transplantation and played an important role for cancer cells and the virally infected cells. So in fact, in this in vitro study, we confirmed liver NK cells exhibited a strong cytotoxicity against hepatocytes in the presence of various immunosuppressive drugs like tacrolimus, cyclosporin, and methylprednisolone. So why do we use liver NK cells? Because liver-resident NK cells are potent anti-tumor activity, quite different from peripheral blood NK cells. Two types of NK cells exist in the peripheral blood, CD56 dim and CD56 bright cells. And this CD56 bright NK cells can go to the liver. However, liver-resident NK cell is this green one is completely different from peripheral blood in the phenotypically and transcriptional difference. Liver-resident NK cells lose the inhibitory receptor KIR that recognize self-MHC class 1 and also express the activation ligand 12 that recognize the cancer cells, this receptor, to inducing the apoptotic cell death. So this slide shows the characteristic of NK cells using the liver pulsate and the peripheral blood from living donor liver transplantation. This flow cytometry is the T cells, NK T cells, and the NK cells representing. So as we can see here, liver has a large percentage of NK cells compared with peripheral blood. And also, activated with IL-2, NK cells express the high level of 12. And also, had a strong cytotoxicity against HCC hepatoma cell lines, only liver NK cells. So if we look at the expression pattern of DES receptor and decoy receptors in the normal liver tissue, we can see here DES receptor and decoy receptor does not express a normal hepatocyte. And well-differentiated HCC has a little bit expression of both receptors. In contrast, moderately and poorly differentiated HCC do express only this receptor, do not express decoy receptor. So this is indicated the susceptibility to mediating cytotoxicity by NK cells. So to investigate the effect of hepatectomy, we use the 70 hepatectomy mice model. So this slide shows the TRED expression after hepatectomy. So TRED expression temporarily decreased after hepatectomy. So 3 days after, TRED expression is significantly decreased and then gradually recovered. So, this is suggesting the temporarily downregulated in the natural defense of activity of liver immunity. So we analyze the liver tissue 7 days after inoculation of tumor cells from the portal vein. On the upper side, untreated mouse, we didn't see any tumor cells. However, in hepatectomized mice, a lot of tumor cells grows up in the liver. So that means due to the transient breakdown of natural defensive activities. So we use this mice in the liver metastasis model. We injected TRED expressing NK cells through the tail vein to this mouse. So tumor growth significantly decreased by the TRED expressing NK cell injection. So similar pathological condition may be portal hypertension. So we use a portal hypertension model by hemiportal ligation. As with a massive hepatectomy, portal hypertension also reduces TRED expression of liver NK cells and also reduce the cytotoxicity after portal ligation of liver NK cells to the hepatoma cell lines. So to address the mechanism underlying TRED downregulation of NK cells after portal ligation, the remnant liver tissues were subjected to microarray for detecting inflammatory gene expression signature. So IL-33 was detected as key molecule contributed to decreased TRED expression of liver-resident NK cells after the portal vein ligation. Candidate gene approach identified the TRED pathway liver NK cells. So we divided TRED positive NK cells and TRED negative NK cells were isolated and subject to upstream regulator analysis. So we confirmed IL-33 and ST2 signals going to the trail. So it means the MAP kinase 1 and FOX1 increase and also TRED decrease pathway. So in this pathway shown here, IL-33 reduced TRED expression in the liver-resident NK cells. So what happens in NK cells in the liver transplantation? So to examine the liver-resident NK cells after liver transplantation, so we use a congeneric mice to distinguish between donor-derived cells and the recipient-derived cells. So this flow cytometry upper left cells representing the donor-derived NK cells, and the lower right representing the recipient-derived NK cells. So with this time point, we check the NK cells in the liver and the spleen. So in the spleen, the lower panel, donor-derived NK cells here barely exist immediately after liver transplantation. However, upper part in the liver, donor-derived NK cells exist for a long period. And as with hepatectomy, 12 expression of liver-resident NK cells is temporarily decreased after liver transplantation. And more surprisingly, only donor-derived NK cells can activate it after liver transplantation, expressing this red one. Blue one is a recipient NK cells. Recipient-derived NK cells does not activate it. So that's why liver-resident NK cells play an important role in intrahepatic immunity after liver transplantation. So this is summary one. Unlike peripheral blood, liver-resident NK cells have potent antitumor activity mediated by TREL, even in the immunosuppressive state. After hepatectomy, portal ligation, or liver transplantation, TREL expression of liver-resident NK cells decreased, and IL-33 plays an important role. Donor-derived NK cells play an important role in maintaining intrahepatic immunity after liver transplantation. So let's move to clinical setting donor liver NK cell therapy. Here is an overview of liver-derived NK cell therapy. So when liver is taken out from the donor, liver is perfused from portal vein, and the liver lymphocyte extracted from hepatic vein. So these lymphocytes are activated to IL-2 for 3 to 5 days. And 1 day before the administration, anti-CD3 molecular antibody is added to the culture medium in order to deplete the T cells. And then 3 to 5 days after liver transplant, this product is intravenously infusion to the recipient only one time. So this slide shows a phase 1 study in Hiroshima University. Almost patient infected HBV or HCV, and the median infusion cell number is 273 million cells. And 45% of patients had revealed pathologically exceeding Milan criteria. So this slide shows the disease-free survival according to the cell dose of infusion. This blue one is a large dose group, have a better survival compared with small dose group. To evaluate the possible HCC preventive effect of this immunotherapy, we compare the recurrent-free survival of this therapy with that of historical control. As we can see the right side, if the patient had a pathological exceeding Milan criteria, NK cell group had a significantly better survival compared with control group. So we examined the cytotoxicity of recipient peripheral blood. So cytotoxicity of NK cell is an immunotherapy group had significantly recovered. However, without immunotherapy group did not change of the peripheral blood NK cell activity. So this slide shows the chimeric status of recipient peripheral blood after NK cell infusion. We use recipient HLA and donor HLA to divide the cells, peripheral blood NK cells. This population comes from donors. So this population gradually decrease, but still exists up until 1 month. We have collaborated with University of Miami from 2009. After approval of FDA, phase 1 study was conducted, 18 cadaveric donors, and median infusion cell number is around 200 million cells, and half of patients reviewed the pathological exceeding Milan criteria. This table shows all patient demographics. The first patient was removed because of the pathology revealed hepatic sarcoma, not HCC. But among 70 cases, 3 patients died because of HCV, graft failure, and infection. However, no patient had recurred HCC after liver transplantation. So this graph shows the patient survival according to the infusion cell dose. Like a living donor setting, high dose group had a significantly better survival compared with low dose group. This graph shows the NK cell characteristic after NK cell therapy. The actual count of NK cells significantly decreased after liver transplantation, but after inoculation of NK cells, significantly increase of NK cell number. And also some NK cell activating marker, TRAIL, CD69, NKP3046, NKG2D226, increase after NK cell infusion. So this is a summary of phase 1 study. Out of 24 patients, 2 patients had recurrence, HCC recurrence in Hiroshima study, but in Miami study, no HCC recurrence. Half of patients presenting with pathologically exceeding Milan criteria. No GVHD and cell infusion related adverse events after NK cell infusion. So in conclusion, liver NK cell immunotherapy could be applicable to both living and cadaveric donor liver transplantation, improve the prognosis of patients with advanced HCC, and augment the NK activities of liver transplantation recipients. So thank you for your kind attention.
Thank you for your wonderful presentation. Now let's open questions and comments from the audience. Yes, please.
And thank you for your excellent oral presentation. I'm Dr. Liang Ping from China. I would like to know, do you have more experience use the UCB blood transfusion to treatment the HCC?
Thank you for the question. You mean the UCP? What is UC?
Unblantical blood, unblantical cold blood.
Cold blood.
Yes, cold
okay.
blood.
Thank you for the question. We have not experienced cold blood, but we generated from the peripheral blood CD34 cells to generate the NK cells. And these NK cells attack the HCC after hepatectomy. So we now using these cells in the clinical setting. So phase 1 study. Yeah, thanks so much.
Yes, Dr. Higuchi, please.
Thank you very much for excellent result, even with both living and cadaveric transplantation. My question is, you obtained the NK cells from the graft using the perfusate.
Yes.
And how much do you perfuse it? Because in relation to machine perfusion, it is very interesting for me to reduce NK cells in the graft. It's relatively, I'm confused a little bit. And how long would you take to proliferate your NK cells to 210 to 6 cells?
Yes.
How long does it take to obtain such a large number? That's 2 questions.
Thanks so much. First question. So liver biopsy method is the same as the clinical setting, so that the UW solution and the Solract solution.
Just a couple liter.
Yeah, just a couple, 1.5 liter or something like that. And we get the liver biopsy, liver lymphocyte around 500 to 1,000 million cells. After culture, this cell number decreased.
Oh, decreased.
Yeah, not proliferate.
Okay.
So,
what do you speculate at the machine perfusion? If you do the machine perfusion, NK cell can be flushed, and the immunity of the liver can be damaged. That was maybe Professor Odan's question for me. What would you speculate?
Thank you so much. So probably machine perfusion or some pressure to the portal vein, so we can get more number of NK cells. So kind of various approach to perfusion. So we're gonna make some trial to pressure change.
So my question is, machine perfusion can diminish the NK cells in the graft to make it worse in the graft without NK cell transplantation. Wouldn't it be possible?
It could be possible.
Yeah.
Machine perfusion probably resulted in the reduction of natural killer cell proportion among the liver tissues.
Yes.
So I haven't seen yet this possibility, but I think that's a very important issue for the further studies.
Yeah, because of perfusion, circulation. So I think putting it back, but I'm not sure how much it is removed.
If you look at the pathologically, the liver remnant natural killer cell, resident natural killer cell, a lot.
Yes.
So even after perfusion, you still can see the resident natural killer cell in the pathologically. Probably even the perfusion, cold perfusion, you still have a natural killer cell in the liver tissues.
Okay.
But nobody knows that yet.
Thank you very much.
Any other question and comments? Professor Hasegawa, do you have any? Okay. Let me ask a question. So I guess the immunosuppression protocol is very important and difficult for this therapy. So could you explain any special aspects of immunosuppression therapy for this NK cell therapy?
Thank you for questions. We don't change the immunosuppressive regimen in this therapy because NK cells maintain the activity in the normal immunosuppressive drugs. So that's why we don't change the protocols.
Okay, thank you very much. Questions and comments? Okay, thank you for your wonderful lecture. I hope the combination of NK cell therapy and machine perfusion will lead to the excellent prognosis for hepatocellular carcinoma. Thank you very much.
It's a third speaker, Professor Denis Belusi here. Professor Denis Belusi, he haven't registered yet. Oh, he? No. Well, I just gonna skip this talk. And the fourth speaker, Professor Murat Hampuruogram. I'm sorry about my pronunciation. I'm going to talk about liver transplantation in a patient with hepatitis B and hepatocellular carcinoma. Thank you very much for joining us our meetings. Please commence your talk.
Dear chairmen, dear colleagues, before presentation, I would like to thank the organizing committee, especially Professor Omata, Professor Abdülkadir Dökmeci. My topic is liver transplantation in patients with hepatitis B and HCC. This is my presentation plan. Firstly, HPV in HCC. later, HPV in HCC carcinogenesis, HCC recurrence after liver transplantation, HPV recurrence after liver transplantation, and prevention of HPV and HCC recurrence. Hepatocellular carcinoma is the fifth most common cancer and the third most common cause of cancer-related death worldwide. Most patients with hepatitis B HCC have cirrhosis. Due to cirrhosis, curative resection is often limited, and the preferred treatment is liver transplantation. In 2015, globally, hepatitis B virus infection is the most common liver cancer deaths, 33%, and the other causes here. In some areas, especially Latin America, East Asia, and Western Africa, and the very high rates, we see the very high rates for hepatitis B virus for primary liver cancer. HPV in HCC carcinogenesis is multifactorial, virus-related, host-related, dietary factors, and lifestyle factors. Hepatitis virus-associated carcinogenesis is a multifactorial process involving direct effect of viral proteins and indirect mechanisms through chronic inflammation and immune evasion and the integration of HPV DNA. Majority of patients, progression to cirrhosis with indirect oncogenic effects leads to HCC development, and up to 1/3 of patients direct HPV oncogenic effects. These are insertional mutagenesis, chromosomal instability, and especially X protein, hepatitis B X protein, caused HCC development. And integration of HPV DNA into the host genome may result in genomic instability, and especially some proteins, protein HPX, may result in uncontrolled cell proliferation, and some particles, for example, DAME particles or subviral particles, may contribute directly to tumor development. And some other factors are important. Firstly, HPV S antigen levels higher than 1,000 resulted in 12.7-fold increase in HCC risk. And HPV DNA levels higher than 1 million copies, HCC incidence rate significantly higher than HPV DNA levels less than 300. HPV DNA survival relationship between who were HPV DNA negative at the time of transplant had significantly better graft survival and overall survival than those who were HPV DNA positive at the time of transplantation. We know that S antigen carriers have a 39-fold increase of developing HCC compared with non-infected people. In HPV-related